Hello, everyone. My name is Amanda Watson. Um, I am doing my Module 1 assessment for NM 702. I wanted to use a PowerPoint because I wanted to share a visual that was in the Camtasia from Module 1. In order to answer this question, what memories do you want your clients to have of the care that you provide? What things will you incorporate into the care that you provide as a midwife WHMP to ensure these memories are made? So this is the midwife relationship model. And the reason that I like this visual is because to me, it resembles a living symbiotic relationship between the mother and the midwife. And out of this, I apologize, I have a sick child sleeping on my lap right now. Out of this, a mother is born. Not only is a baby born, but a mother is born, a family is born, fathers are born. And so this is a huge responsibility that we carry, but it's also a really beautiful and really sacred relationship. And I want the women and the families that I'm taking care of to feel that I honor this sacred relationship between us. In the making room at the table for obstetrics and midwifery and the cultural, to maintain the culture of normalcy article, she says that the healthcare provider is the most powerful determinant of birth outcomes. And I feel like that is a huge statement and shows the amount of responsibility that we have as certified nurse midwives and women's health nurse practitioners in how we care for women. And the Rotham article and also the Jordan et al. In some sense speaks to making mothers. And the Rotham article says birth is about making mothers strong, competent, capable mothers who trust themselves and know their inner strength. So this goes back to this concept of trust. Not only do I want the mothers that I'm working with to trust me, I want to instill in them a sense of inner trust in themselves where they feel that they can make empowered, educated, intuitive decisions for themselves about the care of themselves and their babies. The Rotham article also talks about how this concept of seeing that women are turned away from themselves and of that inner knowing. And maybe as a nurse midwife, if I can hold up a proverbial mirror per se and turn it back to them so that they can see themselves as opposed to having someone show them their baby or show them their strength. Also, the individualized care, as of it's great that we have all of these guidelines for prenatal care, but we want to make sure that we are not trying to impose a one-size-fits-all model onto every single woman. And that also goes back to cultural competence and really understanding the context in which families are coming from. Going back to the model, not only are women surrounded by their own cultures and their own families and partners and children's, but then the midwife herself or himself is also surrounded by their environment and their practice as well. So that can be very empowering, or it can lead to some of the barriers. But in this individualized model of care and instilling trust in women is also this shift of authoritative knowledge being placed back into the hands of women, which Jordan et al. Talks about. And also, which is in the Hansen et al. Article as well, especially when we're talking about the informed consent process and empowering women to feel that they are prepared to make these informed choices for themselves. Um, so, quickly, some of the barriers that I see as impeding my ability or being a challenge to implementing this vision of care and relationship that I would like to make with the women that I care for is a reliance on technology. I mean, obviously, this is something that is not only happening in hospitals and in primary care centers, it's in our models of and guidelines of prenatal care that we follow, even though the evidence is lacking to really support whether or not this technology changes or improves outcomes, and is kind of a way of marginalizing midwifery care when in fact midwifery care does have the evidence supporting that we do improve outcomes. Um, and I believe it was Akil Swaran that said that midwifery is a profession of touch and low technology, and that even though we may be integrated into a physician practice, if we are giving if we are giving our care in a high-tech environment or high-tech labor units, then just because the midwifery care has been integrated into the practice doesn't necessarily mean that we are able to always practice in the way that we want to. And this can mean that, you know, going down to the intra-professional discord, this could mean, meeting resistance when you want to do intermittent monitoring versus continuous electronic fetal monitoring during a otherwise low-risk labor. And even this concept of risk versus normalcy, promoting normalcy and avoiding some of the interventions when they would otherwise be used because of this view of a woman as being high risk. And, how do we advocate for normalcy in this high risk environment and maintain that level of respect and camaraderie with our physician counterparts, and without making them feel marginalized in the care setting as well. Language being, leaving a lasting impression on women and families, making sure, as the Jordan et al. Article says, not to use interpretive labels like high risk or abnormal, and rather to just explain the absolute risk instead of a relative risk, and using words that are very that are more accurate and more powerful, like non-indicated ultrasound, elective induction. And that also goes to say that, elective procedures are something that the patient population is demanding and it feels that they have a right to. And this also could be a challenge in implementing a style of care that honors and supports normalcy and physiologic birth and non-intervention when things are following a course of normal. So it's definitely an art, and I feel that keeping conversation and receptivity of the provider open and absorbent so that you are listening to your patient and you're listening to where they're coming from. They may be in a culture that is surrounded by media. They may be in a culture that is surrounded by fear. And how do we help this person walk this journey in a way that they feel safe and they feel that their viewpoints are respected, while also providing evidence and education that brings them to the other side of this journey feeling more empowered and feeling like they had the birth experience that surpassed their expectations. And now I'm going to stop. Thank you very much.